Respected Dean HPE, heads of the departments. It is my pleasure to invite Dr. Narayan Parameswaran to AVMC webinar talk on behalf of the management and the university. It is a great pleasure to introduce your own student. He was one of my bright students. Not that others are not bright. All my students are bright. He is very bright. So, he has done MBBS, MD from JIPMER, DNB from the National Board. Then he is working continuously in JIPMER in various capacities. Presently, he is heading the Department of Pediatrics, and it is a very happy occasion to me. He is a humble and simple person. He does not talk much, but he shows in action. All postgraduates like him very much, because obviously, if you teach them and if you don't scold them, all postgraduates are very happy. So he's very nice to them. Then he has gone to Australia for 1 year training in intensive care, and he has other trainings, like he's a pulse instructor, and has been trained in critical care ultrasound, and he has several other trainings like on clinical research methodology, fundamentals of biostatistics, and the incline training on leadership and management program. So several trainings he has undergone. In addition to that, online Oxford Harvard training in clinical trials, epidemiology and biostatistics. These trainings also he has undergone. He has got vast experience. He is a very learned person. He is very knowledgeable. He has got one provisional patent also on non-invasive body fluid monitoring. I wish that he gets a permanent patent for that. He has got 4 research grants, and total amount exceeds more than 10 crores. And he has published 68 papers in various national and international journals, and written about 5 chapters in textbook. He has been awarded International Rising Star Award for the best presentation in the World Congress of Intensive Care in Melbourne, Australia. So I don't want to come between you and Dr. Narayan. I am sure that he will enlighten all of us on acute respiratory distress syndrome in children, how he manages, and also will answer your questions, whatever doubts you have. Thank you, Dr. Mahalakshmi. You can take over now.
Yeah. Thank you very much, sir. Before we proceed, a few housekeeping announcements. This session is being recorded for academic purposes and also for posterior use. And if you will notice the right upper corner of your screen, you can see that this is being live streamed in YouTube also. So you can actually go back and watch this session whenever you want. And for the purpose of audio quality, I would request all the participants to mute themselves, and whatever questions they have, comments and discussions they want to have with the speaker, please use the chat box option. Over to you, Dr. Narayan. You can share the screen now.
Thank you. First of all, I would like to thank Dr. Dr. Bhatt, my professor, and Mahalakshmi, and Dean, and the entire scientific team in AVMC for inviting me for this talk. I also thank Dr. Bhatt for such a warm and I think it is don't deserve such a great introduction. But thank you, sir. I hope we can live up to your expectations, and it's a great honor to present in front of your teachers. So let us start the presentation. I'll just share the screen. Yeah, is it visible?
Yes, Naru, you can go ahead.
Yeah. Yeah. So today's topic has already been mentioned. That is pediatric ARDS. We chose this topic because we thought it is relevant to the already the dean sir has said that it is quite relevant to the current COVID pandemic. But there are a few disclaimers. I am not going to deal with the adult ARDS. I restrict myself to the management of pediatric ARDS because that's where our experience is. and I am not going to deal with COVID-specific management. ARDS, the supporting management only we are dealing. COVID-specific therapeutics, we are not going to deal here. It's a discussion on ARDS. So let us start with this topic. I thought we will discuss in terms of a case-based discussion, one of the cases which we recently managed during the COVID pandemic. So we will take the discussion around the management of the case. So we will deal with the definition of ARDS, understanding the concept, how the definition has come across, pathophysiology, yes, 1 or 2 slides, then the principles in management and the current status of the respiratory support. This is where the theme of this talk comes in, where there's a lot of technology has come in the respiratory support. So they're not very recent, they are old, but I think it is time so that we are all familiar with that. So let us start straight away. The index child is a child who are admitted in the last June with us, 9-month-old baby. So the baby came with a fever for 3 days, cough and coryza for 3 days, and respiratory distress for and cough and coryza for 3 days, and respiratory distress for 1 day. And on examination, child was tachypneic, increased work of breathing, subcostal and intercostal recessions. Auscultation revealed bilateral crepitations, and child was saturating 96% on oxygen by nasal prongs. SPO, all of us are aware of the SPO2 in COVID pandemic. Even we are doing home monitoring with SPO2 monitors. So this indicates that child had a most probably infection involving the respiratory system and most probably a pneumonia. So the child was admitted with a diagnosis of SARI, severe acute respiratory infection. That is the current pandemic definition. Child tested negative for COVID by RT-PCR. And this was the child's chest X-ray at admission. As you can see, there may be a small hastiness on the left upper and mid zone. But the interesting thing is that there is pediatric people or the physicians may be noticing this. There is a small air leak sign here. The diaphragm is seen clearly. This normally you don't see diaphragm fully here. It's called a continuous diaphragm sign. So that shows that there is a air leak here. So child features of air leak, we consider diagnosis of necrotic pneumonia. Pneumonia which is producing damage to the lung and air leaking out of the lung. So the commonest organism in this age group should be a staphylococcus. So child was treated for that. Now the question for today's talk, its relevance is, does this infant have pediatric acute respiratory distress syndrome? We call it PARDS, pediatric acute respiratory distress syndrome. So child is a pediatric age group, so that is satisfied, and A is acute. So yes, this child had an acute illness lasting only 3 to 4 days. Of course, there's a respiratory issue. And distress is there, but we're not sure whether the distress is severe enough to call it ARDS, and why it's called a syndrome. We're not sure whether it's a syndrome. Okay, so we're not sure this child has ARDS. So let us see how we can define ARDS. So just to put the things in context, this is the history. So ARDS has been known only for the last maybe say 40 to 50 years. The first description was in 1967 by Ashberg et al. They described around 17 adult cases which they call acute respiratory distress syndrome. These patients had multiple illnesses, like some of them had shock, some of them had surgery, some of them had infections, some of them had some chemical pneumonia. All of them had lung damage, producing severe hypoxia, which is almost looking similar to a cardiogenic pulmonary edema. But the heart function was normal. So the same group published a few more series in 1971. That time they changed the name to adult respiratory distress syndrome because they felt that this condition mimics the respiratory distress syndrome seen in preterm babies due to surfactant deficiency, where the lung is very stiff and difficult to ventilate, and the child is very hypoxic. Subsequently, people started calling it different names and publishing it. So in 1994, there was a consensus conference where they defined what is ARDS and ALA. Formal definitions were given. It is an American and European consensus conference. Mind you, all these are adult definitions. In 2011, there was a further improvement in the definition. That's called the Berlin definition, which is currently being used in adults. So that was in 2011. The pediatric definitions came only in 2015, actually. So the first definition of pediatric ARDS was by this group, the Pediatric Acute Lung Injury Consensus Conference, PALIC group. They defined what is ARDS. So to understand this, let us look at the pathophysiology of ARDS. So towards the left of your screen, this is the normal. This is an alveolus with a capillary adjacent to it. The left side is the normal alveolus. The right half is the abnormal alveolus. So whenever there is an injury to the alveoli lung, which can be multifactorial, like I already mentioned, like Ashberg et al. Also said that it could be infection, it could be peritonitis, or it could be an inflammatory disorder, it could be pancreatitis, trauma, shock, any injury that can activate your macrophages and neutrophils predominantly, your inflammatory system, immune system, and they can come and damage your alveolar epithelial cells. So when alveolar epithelial cells are damaged, the fluid will leak from the capillaries into so both the capillary endothelium as well as the alveolar epithelium is damaged. So protein-rich fluid can leak into your alveolus. So this is something similar to pulmonary edema. The alveoli get filled with protein-rich fluid and inflammatory cells. So, but mechanism is not cardiogenic; it's inflammatory edema. So this is the first phase of ARDS. Multiple stimuli can lead to this non-specific response. This is called the exudative phase. This is followed by usually 2 more phases. The next phase is the proliferative phase, where there's some repair will happen, and the body's immune system will try to repair it. Sometimes the leaks get mended, and the fluid get reabsorbed, and patient can get better. So, but this phase is called the proliferative phase. But sometimes, rarely, if the insult continues and the patient responds in a non-favorable manner, they can undergo fibrosis. If patient goes this phase, usually the prognosis is poor. The lung may get permanently damaged, they may never recover, and we may lose the patient. So, but not all of them will go into the fibrotic phase. Some of them will recover from the proliferative phase. This is the pathophysiology. Now, the question, we come back to the same question: does our child have ARDS? So, definitely, this child has parenchymal involvement. We have seen by X-ray and our clinical finding there is lung involvement. The child has impaired lung function for sure, so child needs oxygen, and a child needs the respiratory distress. Now the question is, how objectively do you assess the function of lung as an oxygenator? Because when the lung function is deteriorated to a certain level, we call it ARDS. So how to objectively assess? That is the key point in defining ARDS. First of all, clinical exam. Clinically, we can find out how bad the lung is, but assess is very not reliable, especially small infants, and it's non-specific sometimes. Okay? And children with neuromuscular disease, they may not have any distress. And some of the small babies even can have apnea as a manifestation of any pneumonia. But what about SpO2? This is what we commonly use nowadays. So saturation, oxygen saturation in the blood, you don't basically measure at the fingers. Okay, of course, it's reliable. Okay, but there are some caveats. SpO2 can have sometimes, if the peripheries are cold or patient is in shock, he may not pick up. Then we can use something called partial pressure of oxygen. All of us know this. This is the same level of oxygen. We take a blood sample usually from the arteries and check the level of oxygen straight away usually by an arterial blood gas machine. So we can directly measure the oxygen in the blood, which is more invasive. And we cannot do it frequently, but it can be done. Is there any other parameters? Okay, so are these 2 things sufficient to objectively assess the function of lung as an oxygenator, or do we need anything else? So to understand this, I will show 2 scenarios. Compare these 2 children with pneumonia, say child A and child B. So child A has an SpO2 of 95, child B has a SpO2 of 90. What do you think is a sicker child? Straight away, for us, it looks like child B is sicker because SpO2 is lower for child B. Correct? We assume that child B is definitely sicker. Okay. But suppose I give you one more information. For example, I say that child A is actually on an oxygen supplementation by a non-rebreathing mask. This is an oxygen delivery device which can give high FiO2. So the child is on a sorry. Yeah, sorry.
Continue.
So there was this child is on an FiO2 of 80% oxygen, and this child is on room air. So suppose I give you this information, then suddenly you realize that the child with SpO2 95 looks more sicker because child has achieved this with great support, but this child is on room air and is able to maintain at 90. So this is what I call is important. Not only the SpO2, the oxygen level in the blood has to be interpreted in the context of how much support the patient is on. So for this, there can be have a measurement of the objective measurement of incorporating these 2 things. So that's where the PO2 by FiO2 ratio or SpO2 by FiO2 ratio comes. So we take the ratio of these 2. What is the measured oxygen divided by how much oxygen child is receiving? Okay, if you do either you can take it, you can use the PO2 in the blood, or you can use SpO2 in the SpO2 monitor, non-invasive monitor. Then it's called SF ratio. So normal values are above 400 for PO2 by FiO2 ratio and more than 450 by SF ratio. This is simple, correct? Suppose the SpO2 is 99 on room air. That means 99 divided by 0.2, because 20%, 21% oxygen, that will come to how much? Around 450 and above, correct? So that is for normal people. Okay. Now, is that sufficient? Now, with this information, let us look at these 2 children again, child A and child B. If we calculate SF ratio for both of them, we realize that SF ratio is 119 for child A and 429 for child B. The lower these values, the worse the lung condition. Okay, so this condition definitely lung is much worse. SF ratio is much worse for child A. Okay, fine. Is that sufficient, or do we need something more? Okay, so let's compare these two children with pneumonia, child A and child B. Child A has a speed of 92, child B is 94. Okay, first glance we think child A is sicker, but now we are wiser, no? We asked for, no, I want to know how much supplementation patient is on. So child A is on 80% of FiO2 and child B is on 40% of FiO2. Oh, good. Then we will think that definitely which child looks sicker. We definitely say that child A looks sicker because higher FiO2 I needed to maintain a speed of 92. Okay, fine. Yeah, but then, so that's our impression is because we learned that SF ratio and we need to consider both of these. But then suppose they give you one more information saying that, yeah, here, this is the same thing I calculated. So SF ratio is lower for this side. So definitely this side is sicker. But suppose I give you one more information saying that child A is actually only on oxygen supplementation, but child B is on a ventilator with the positive pressure ventilation. We're using pressures of 10 MAP, PEEP 6 and all that. PEEP is the pressure during expiration, the ventilator uses, and PAP is the pressure during inspiratory phase of respiration. Okay, and this average pressure is mean airway pressure. So that means, so we realize that this child, then suddenly the child B looks sicker, even though the child is going to have higher SF ratio. So we learned that not only the oxygen percentage is important, it's also important to know whether child is on any extra pressure supplementation. This is also important. Pressure is also important. Why is pressure is important? For that, let us look at the schematic diagram which I prepared. This is an alveolus. Okay, this circle is an alveolus. This is the capillary, alveoli capillary. How does oxygen enter from alveoli to the capillary? The pressure of oxygen in this alveoli is what drives it. The PaO2. It's called P capital A-O2, partial pressure of oxygen in the alveoli. That drives the oxygen across the concentration getting into the capillaries. Okay. So that for the capillaries, you get more and more oxygen. So what does this partial pressure of oxygen mean? That means the pressure of exerted by oxygen in the alveoli. Suppose when we normally breathe, the alveoli has atmospheric pressure, and suppose it's it's sort of we call it 760, and normally around 1/5 is oxygen, correct? What you breathe, 20%. So the pressure exerted by oxygen out of the 760 in the alveoli will be around 1/5 of that. Okay, around 100 to 150. Where water vapor also is there, of course. So around 100 to 150 is the PaO2. Suppose I want to increase this PaO2. Correct. I can do two things. I can give more oxygen. So suppose oxygen FiO2 is 50%. That means out of this air in this alveoli, half is oxygen. Then out of the pressure of 760, half of the pressure will be exerted by oxygen. Then it comes 760 divided by 2, it becomes 380. Suppose the alveoli is at atmospheric pressure. Okay. So one way of increasing the pressure in the alveoli of oxygen pressure is to increase the oxygen content of the alveoli by increasing the FiO2. Another way also we can actually increase the pressure into the alveoli. This pressure can be made more than the atmospheric pressure by externally give positive pressure. Then suppose total pressure increases, then pressure exerted by oxygen also will increase. So we learned that partial pressure of oxygen, which is the pressure exerted by oxygen in the alveoli, it depends not only on the concentration of oxygen, but also it depends on the pressure in the alveoli, the actual airway pressure. Okay, suppose in this scenario, suppose that 50% FiO2 is there and atmospheric pressure is 760, total pressure in the alveoli is 760. So 380 will be oxygen pressure. Now, if I make the alveolar pressure twice the atmospheric pressure, the oxygen pressure also will go to twice the atmospheric pressure. Okay. So now you learn that alveolar pressure of oxygen depends on is the pressure exerted by the oxygen in the alveoli, and that drives the oxygen into the capillaries. So that depends on two things: composition of air, the FiO2, as well as the pressure, the mean airway pressure in the alveoli. So now we realize that to get a complete picture of the lung of function as an oxygenator, we need to have these three parameters. So that's called oxygenation index. We need to have pressure as well as FiO2 along with the oxygen measurement. Okay, so these three things, if you take to really, we get a complete picture of the damage to the lung or the function of lung as an oxygenator. So if you use PaO2, it is called oxygenation index. But if you use the same formula, if you replace PaO2, that is arterial sample, instead of that you use SpO2, this is called oxygen saturation index. Okay, but it's basically the same. So this ratio, if it is higher, previously SF ratio and PF ratio, the lower the value, the worse the lung. This one, since we inverted it, you brought a PaO2 and a SpO2 down. So the higher these values, the worse of the lung condition. Okay. So now we learned how to assess objectively the function of lung as an oxygenator. Now we try to define what is ARDS. This is the current definition given by of ARDS given by the Pali group in 2015. So age limit. All children expect the outside the neonatal age group. Okay, because neonatal age group, the pathophysiology, everything is different, so they are excluded from this definition. Timing is important. It should be an acute problem within 7 days of clinical insult. The ARDS cannot be diagnosed after 7 days of clinical insult, so it should be a recent problem. And the edema of the lung fluid filling of the lung, the alveoli filled with fluid, that should be respiratory failure should be not be explained by cardiac failure. So you need to rule out significant myocardial dysfunction. That depends on how you rule out, depending on your local available resources. You can do an echo, or you can do clinical examination, X-ray, whatever is available to you. But you need to rule out a significant myocardial origin of the edema. Then imaging should show new infiltrates consistent with acute parenchymal disease. You should have some parenchymal infiltrates. It need not be symmetrical, but it preferably should be bilateral. Okay. But it need not be symmetrical. Then, if the patient is not intubated, then this is the definition. Patient is non-invasive ventilation. All of us know what is non-invasive ventilation. We use a mask or an interface or a prongs, and we use a machine to give air at higher pressure without intubating the patient, without putting a tube into the lung. So if your patient is on non-invasive ventilation, then this is the definition. The PF ratio we use, because there we cannot get the map because we cannot measure it. So we don't have we use only PF ratio or SF ratio. This is the cutoff. If the patient is intubated, we use oxygenation index or oxygen saturation index. So then we classify them into 3 groups. Okay. So 4 to 8 of oxygenation index is mild, 8 to 16 is moderate, and more than 16 is severe. Similar values for saturation index are different. Okay. So this is how you diagnose pediatric ARDS. Okay. All right. Now, some definitions for patients at risk for ARDS, so that we can identify them early and monitor them carefully whether they're developing ARDS. So these are the definitions for that. I'm not going into too much in the details, but basically they don't meet the criteria for ARDS, but they're on some amount of oxygen supplementation. Okay. We'll skip that. We don't go into the details. So let us see. Now, our child, a 9-month-old baby, has ARDS, yes or no? This child is a nasal prongs and explode of 96. So this does not satisfy definition for ARDS, but it satisfies definition for at risk for ARDS. That means this baby is at risk for ARDS. So now we diagnose at risk for ARDS, we start management. So this is a timestamp of the child's events what happened over the next few days. So day 1, child had fever, respiratory distress. We diagnosed necrotizing pneumonia, and child was on oxygen prongs. Then by day 2, child had sudden decreased air entry on the right side with the desaturation. This child already had air leak. We suspected pneumothorax. And child respiratory support has been escalated to a high flow nasal cannula at the FFF of 80%. An intercostal drainage was placed, and since child worsened, child was shifted to the ICU for further monitoring by end of day 2nd, day 3. And one child is ICU, child was on NIV. That means by prongs we are giving the controlled FiO2 and also PEEP of 5, some pressure by the machine. But child is not intubated. So the saturation was around 94 with an FiO2 of 50%. Now, if we calculate the SF ratio here, this is 188. This satisfies definition for ARDS. So that means now the child has developed ARDS. We less than 265 is ARDS. So this is ARDS. So PRDS criteria is met. Now this child has ARDS. Now we know how to manage this child. We'll discuss. So how do we manage this child now? So the most important thing which we forget while managing a child is we should realize what the underlying condition which is produced ARDS and manage the condition well. If it is infection, cover with antibiotics. If it is some immune process, give immune suppression. If it is shock, manage the shock well. That is very important. Then supportive management is all equally important. Otherwise, child can die. So the main aim of supportive management is to prevent further lung damage. I showed you the pathophysiology of ARDS previously. All the lung is damaged with all the information leaking. Okay, so that lung can get further damaged if you inflate the lung very badly. Okay, that lung is very prone for inflation and deflation. If you keep a lung which is partly ruptured alveoli, if you keep on inflating and deflating, it can undergo further damage and they never heal. At the same time, we need to support the baby child's oxygen demand. So these are the underlying conditions which should be forgotten. Appropriate antibodies. This child is given appropriate antibiotics. Source control has to be important. Suppose you find some abscess or some infectious source that has to be drained. And in autoimmune disease, for example, sometimes we have seen patients with SLE or good postures coming with ARDS. Okay, so in those cases, we may give PIM skiers now sometimes. So immunosuppression has to be given. Sometimes we need to give steroids. But the mainstay of this talk is actually supportive management. So I will stick to that. So to prevent further lung damage, I said, no, that is the first thing to do. The best thing is to give complete rest. All of us know that if you have a organ damage, suppose I have a fracture of my hand or something, I need to give rest to the hand. If my kidney is damaged, I give rest to the kidney, I do dialysis. If I have a head injury or my head is damaged, they put me on coma and, that's how you manage patients. So no, the organ has to be given rest. So ideal strategy for life-threatening injury to any organ is to give rest. But the problem is this is not possible with lung. If you give lung full rest, patient will die. Okay, so we need to manage this patient with the injured lung till making the lung function. Okay. That's the trick here. Like it's not like any other organ we can give complete rest, like kidney or a brain. So in conventional ventilation, how do we do this? Is we ventilate very, very gently. We know that the lung is injured, it's leaking. So we ventilate very, very gently. I told you inflation and deflection are higher pressures. Like that movement is what produces maximum damage. So we use very low tidal volumes. Normal lungs we can use up to 8 to 10, up to 12 ml per kilo. But in ARDS we use half that, 4 to 6 ml per kilo. Very, very low tidal volume because we don't want to damage the lungs already damaged. And we accept low oxygenation and high. You know that if you ventilate lung very gently with very low tidal volumes, the oxygenation may not be very good, and the CO2 levels in the blood may go up. We lower our targets. We don't target about 90% or 95% CO2 or so we target 85, 90. They're enough for the child to survive. Okay, so the child can recover. And we accept high CO2, sometimes 70, 80, even 100. Okay, and at the same time, this is also important. We should also try to keep the lung volume optimally expanded. So all of us have read in physiology that there's a volume called functional residual capacity, FRC. So that is the volume at the lung at which the lung has the best mechanical properties. The lung remains at FRC. The lung has the best compliance and easy to expand and all that. So we'll try to keep the lung optimally expanded with whatever external pressure, so that the patient can breathe very easily and we can get better with the least possible pressures. So this is also very important in the management of ARDS. These are the basic principles. Okay, of course, we should have patience after that. Then you have to sit on the patient. Don't get desperate. ARDS patient will not improve in 2 days, 3 days. They take days to weeks. So every second or third day, like in pneumonia, no, child is not improving. Shall you do something more antibiotics, more this thing? No, it doesn't work. Okay, we need to give it time to heal. Yeah. So now, what about prone ventilation? Okay, I'm sure that this is coming in a big way. In fact, government is also giving guidelines that you can even prone at home. So how does it work? So this prone does not do anything to the underlying disease process. That all of us know. It does nothing. No, by changing the position, it does not affect the disease process. Whether it's coronavirus or whether it is staphylococcal pneumonia, anything, it doesn't affect that. It does not do anything to the lung damage directly. The injury, mechanism, it doesn't do anything. Then how does it help? Basically, it improves oxygenation by altering the lung mechanics. Okay, I'll show you a picture for that to explain that. See, this is a CT scan, a coronal section, cross section, okay, of a patient lying supine. Okay, this patient lying supine. So since supine means this is the heart is anteriorly, you can see the vertebra posteriorly. The lying on his back. Okay. Now, if you see the cross section of the lung is like a triangle, or you can say a cone. So top part is narrow and the broad part is lower part is very broad. Okay. So if you look at this diagram, the dependent part of the lung, where the weight of the lung itself as well as the heart, everything will fall on the bottom half of the lung. So there's a large proportion of the lung which towards the base, which is actually under a lot of pressure, and they have a tendency to undergo collapse or atelectasis. And we know that in ARDS there is a lot of alveolar damage. Surfactant deficiency is there because the capillaries are damaged. I mean, the epithelium is damaged, so the lung has a tendency to collapse. So this added pressure on the lung will make sure these areas prone for collapse. So all of the alveoli will collapse off. And all of us know from physiology that the dependent areas of the lung gets more blood flow. So blood flow is more to the dependent area. So blood is coming here, but most of the alveoli are collapsed. So there will be a lot of ventilation perfusion mismatch. Okay, blood is not getting oxygenated. So this is what happens in a normal patient with ARDS if you lie down like this for some time. Anybody with it, not only ARDS, any significant parenchymal lung disease, if you lie down like this, these areas can collapse off. Now, if you turn this patient prone, in this next picture, you can see here, so now the patient is prone, you can see the vertebra has gone up, back is up, the heart is down now. So now the heart is, if you see the lung now, it looks like a same inverted triangle. Now the apex is down, the base is up. So most of the lung mass is now up. Okay. And whatever is only the apical part may tend to have collapse because of the weight of the heart as well as the rest of the lung. So most of the lung, which is collapsed here, if you just turn him over, all the collapsed lung will expand, and this will lead to better ventilation perfusion match. So this is what happens in prone position. Even right now, we have a patient in our ICU, ARDS, whom we just proned day for yesterday. So before proning, the cell was significantly hypoxia. After proning, the oxygen saturation improved, but the proning has done nothing to the underlying disease process. Okay, so it works because it changes the lung mechanics. That's how it works. But there's no point proning when you sleeping normally, it doesn't make a difference. Unless your lung is parenchymal damage is significant, then only this works. Okay. So now coming back to our child, what happened? We diagnosed ARDS, we did all this to this patient, sort of proning. We did conventional ventilation, low tidal volume, and all that. And so this is the child's oxygenation index graph over the next 1.5 months. What happened? If you see the trend, the average OI is around 30. that's severe ARDS. No, above 16 is severe ARDS. Okay. And we know so by day 6, the oxygen index was almost 43 here. So the child was switched over from conventional to another mode of ventilation called HFOV, high frequency oscillatory ventilation. We'll come to that in the next slides. And by day, even after that, child was refractory hypoxia. There was despite HFOV. You can see that even after HFOV, the oxygen index never came down less than 30. It was, in fact, it peaked again, went up to 60, 70, and all that. So around this part, around this day, around day 13, child was in fact went on ECMO. Okay. So we'll discuss this other two management issues in the next few slides. So this is the thing we did on day 6 for this HFOV. This is the machine which we have. So this is a machine. This machine looks scary, but actually, it looks like a giant. But actually, it gives very gentle ventilation. So appearances are sometimes deceptive. This is supposed to be very gentle ventilation. So how does it work? So see, this is these two scary-looking tubes are the tubes which take air to the patient. One is the inspirated limb and one is the expirated limb, and there is a bellows here. Okay. So I'll describe in terms of a schematic diagram how this works. Okay. So here, what does this is an inspiratory limb. That means the tube which takes air to the patient, and this is the expiratory limb which takes air out of the patient. Okay. So there will be a constant flow of air through this at a high flow rate and maybe a slightly higher pressure. This pressure is used to keep the lung expanded at a first. Okay. So we keep the lung expanded at around say close to the functional respiratory capacity, optimally expanded. Then, but that expansion alone will not produce gas exchange. Okay, because if you keep the lung expanded, the carbon dioxide will continuously entering the lung and oxygen will be taken up from the lung by the capillaries. So for gaseous exchange, we connect a pump, a bellows with a diaphragm, okay, to this circuit, and then these things move up and down at a very high frequency. So it produces oscillations. These oscillations will produce oscillations in the airflow, and these small oscillations will produce gas exchange. So this is how it works. Okay. So it looks a little strange how the small oscillations produce gas exchange. So there are multiple mechanisms for this. Nobody has fully understood it. There are so many mechanisms how this happens. If you just gently shake the lung, how the air comes out of it. Okay. So, but this is how. So this is why it is considered very gentle, because lung is kept expanded optimally at a volume of close to FRC, and then we produce low tidal volumes at a high rate. Small vibrations which produce small air movement. The small air movements due to multiple mechanisms which are we're not discussing into too much of detail. That's what needed for this talk. But there are this mechanism is not fully understood, but it produces gaseous exchange. Okay. So basically, HFO produces very small breaths that delivered rapidly at 180 to 900 up to 900 breaths per minute. So we call it hertz. Okay. Starting from 4 hertz to 15 hertz, it can give. Okay. So 15 hertz means 15 into 60 by 900. So at that frequency, it oscillates. So this is a diagram, graph which shows the roughly how it works. So here, this is the pressure in the y-axis, and this is the time in the pressure time scalar. This is, and the solid lines is the conventional ventilation tracing, and these dotted lines are high frequency oscillator traces, HFOV traces. So if you look at this, let us look at the conventional ventilation. How does it work? So this is the expiratory pressure. This is the inspiratory pressure. So during a breath, the pressure goes from expiration to inspiration, stays there for some time, comes down, then the next breath. So there's a lot of fluctuations in the pressure within the airways and the alveoli. Correct? So this, we know that this can produce further damage to the lung. In HFOV, what it does is that, see, it keeps a constant pressure around in the lung, kept expanded with a constant airflow in the inspiratory limb, say around 25 to 30. That depends on patient, depending on lung condition. So in this patient, we kept around 30. Okay, this constant pressure is kept. Then along the constant pressure, we produce small oscillations. These oscillations only actually produces the ventilation. It removes carbon dioxide and adds oxygen to the air within the lung. These oscillations, okay, because when they happen at very high frequency, they are sufficient to wash out the CO2 and impart oxygen into the air within the lung. So you see, the lung is kept expanded and then minimal oscillation. So this is very gentle on the lung. That's why HFO is considered very lung protective, especially for smaller babies and infants and newborns. Okay, so this is a favored way of ventilating especially for neonatology and pediatrics. We like this mode because we feel it is very gentle on a baby's lung. But studies in adults have not shown that. So if you look at the evidence, you can ask us, if you know that this is very gentle, why you didn't use this first time for the patient? You have the machine with you. As soon as the baby had ARDS, you could have used that. Okay. In fact, few of us believe that we should use that. but actually evidence does not show that. So this is the Cochrane systematic review on this topic. Okay, so if you look at high frequency oscillation versus conventional ventilation for ARDS, okay, this is the Cochrane review, the systematic review over multiple RCTs combined. There were two large RCTs in the beginning of early 2012-13 called Oscar and Oscillate. Okay, they both proved that this HFO is not very effective in adults. Okay, so these two trials have tilted the balance. So this is the current evidence for HFO. It does not reduce hospital and 30-day mortality due to ARDS. The quality of evidence is very low. And the findings of the systematic review says that they don't support the use of HFO as a first-line strategy in people undergoing mechanical ventilation. So they don't support it as first. So current evidence does not support it as a first-line strategy. Okay. So that's why we are currently using it as a rescue measure when conventional ventilation fails. So that's what we use in this patient. So we put this baby on HFO on by day 7 because conventional ventilation was not producing any improvement and child was in fact worsening. So this is the picture of the child on HFO. So here we can see the lung is significantly more whiter than before. So there are some areas of aeration, but lung is significantly more whiter. At least the air leak has settled. There is no more ICD has been removed. Okay. Yeah. Now, is there any other options at this stage? Any other advanced mode beyond conventional ventilation? There's something else called airway pressure release ventilation. This is another mode which people use for ARDS. To try instead of HFO or the conventional ventilation phase. So what is this airway pressure release ventilation? So we'll not go into the detail. We just look at the principle on based on how it works. The working principle is that spontaneous breathing is better for bad lungs. Okay, these people who advocate this mode, they believe that spontaneous breathing is better for bad lungs. Okay, we come to that how it happens. I'll describe in the next slide. And so it leads to better recruitment and gaseous exchange of dependent areas in ARDS. Okay, so how to explain that? Look at this picture. So here what we are seeing is it's a spontaneously breathing patient. Okay, spontaneously breathing patient. So their diaphragm is the main respiratory muscle we know, and the lower part of the diaphragm muscle, the superior part as the tendon. So when the diaphragm moves, the movement is much more in the lower part. Correct. The posteriorly the excursion is much more. So what happens is that when you normally diaphragm descends during inspiration, the posterior part of the lung moves more than the anterior part of the lung. So ventilation, this is big arrow. The air goes preferably more towards the posterior aspect, and less air goes to the anterior aspects of the lung. So ventilation is more in the posterior aspects, and we already mentioned that even the blood flow is more in the posterior aspect. So blood flow is more towards the posterior aspect. Air also flows more into the posterior aspect during spontaneous respiration. So there is better ventilation perfusion match. Okay. This is what happens in spontaneous breathing. But when we use positive pressure ventilation, like you see the figure here, mechanical ventilation. Okay, this child is intubated, the tube is missing. Okay. I imagine that it's intubated. So here what happens? The diaphragm does not move much, okay, because this is a positive pressure ventilation. Then in this situation, most of the air goes anteriorly. The dependent part of the lung gets less air. But actually those areas are getting more blood. There is a mismatch between ventilation and perfusion. So this is what happens in ARDS when you do conventional ventilation. So these guys feel that we should encourage spontaneous breathing. We should not let paralyze. Most of us, when a patient is very sick, we sedate the patient heavily, paralyze the patient, or at least sedate the patient very heavily. We don't let him breathe much, and we take over the breathing because it's difficult to control otherwise. So these people who advocate APRV, they feel that we should encourage spontaneous breathing in them. So how they encourage spontaneous breathing? They say. So I said that if the lung is kept at the FRC, close to the functional residual capacity, compliance is best, and then patient may be able to breathe even if you have ARDS. But the ARDS lung is low volume because lung would have collapsed. So use high pressure to get the lung back to FRC and then allow the patient to breathe. So this is a schematic diagram, same pressure time graph which I showed you for a HFO. So let us see how it works for APRV. So here this is a high pressure. So this is the pressure which is somewhere close to 20 to 25 or 30. We keep that. Okay, and patient is allowed to breathe spontaneously at this pressure all the time. So this is the pressure which keeps the lung at the FRC, and patient is allowed to breathe. But if you continue to give this pressure all the time, what happens is that the lung can get overinflated because the entire lung is not damaged. There are areas of the lung which are actually normal. So if you continuously inflate this lung with high pressure, lung may get overinflated and it may affect your CO2 washout. So in between, you come down to a low pressure intermittently, right? For a short time. That's called time for that is called T low, and the pressure during that time is called P low. And this is called P high and T high. These are the four settings we are using in APRV. This will be very short time, less than 0.2 seconds, 0.3 seconds, less than 1 second. This is just to prevent just to empty the lung and so that to prevent hyperinflation. So this release happens in between. So that's why it's called airway pressure release ventilation. Use high pressures most of the time, allow patient to breathe spontaneously. In between, you release to a low pressure and come back fast up. Okay, Most of the high pressure, release, come back. Airway pressure, release, ventilation. Yes. This is what this is a many ventilators, many advanced ventilators right now. Most of the modern ventilators can give this mode as a separate mode. Okay. Yeah. But what is the evidence for this in pediatrics? All right. So this is the only RCT published in pediatrics on APRV. This is published from India, from Chandigarh. This is published in a very prestigious journal, American Journal of, it's called the Blue Journal, the American Journal of Aesthetic Clinical Medicine. So this study, in fact, they had to stop the study in between because of increased mortality. Okay. So this is the final conclusion from the study. As a primary ventilation strategy in children with ARDS, APRV strategy was associated with a trend towards higher mortality. So we should not use that. That's what there's a trend towards higher mortality. So because of this study, and people are now hesitant to use this as a primary mode, especially in pediatrics. And it is advised that this mode is used only as a trial mode. If you're doing a clinical trial, we can use that. But routine patient management, you should be careful unless you are very experienced with this mode, because you can increase the mortality and produce more damage to the lung. That's why we didn't try that in this patient, even though we had access to this. So since HFO also our child failed, so we went off. We put the child on ECMO, not by day 13. So these are the ECMO cannulas. You can see this is the cannula taking out blood from the right atrium and giving back into the aorta. We'll discuss this in the next few slides. So this is the history of ECMO, which I'm not going to go into details. ECMO is started around 1960s, and it's also an around 50 to 60-year-old intervention. It's not a new one, but for us, many of us, it is very new. So there is a ECMO registry. It's called Extracorporeal Life Support Organization. There's an organization here, so they keep the registry. So how many ECMOs are happening throughout the world? People. So if you see, look at this graph. This is the picture from January 2020, like 1 year last year's graph. So if you see this red lines are the number of centers in the world which are doing ECMO. So in 1990s it was less than 100. Now by 2019 it has gone up to almost 450. Now around 450 centers in the world are doing ECMO. And this blue line is the number of ECMO runs, number of patients put on ECMO. It was very less, say around 1,000 patients in 1990 to by 2019 now almost 12,000 patients are put on ECMO. Okay, so the rapid increasing, especially after around 2008-9, there was a rapid exponential increase in ECMO use. This happened during the COVID last H1N1 pandemic. A lot of patients went on ECMO. After that, there's increased interest and suddenly it come up. Now COVID pandemic also ECMO is picking up. So maybe after COVID pandemic, you find again one further spike in ECMO. So how does ECMO work? So this is the normal circulation. So here the blood comes from the systemic circulation, enters the right atrium, right ventricle. From there it goes to the lung. The lung, it gets oxygenated, comes to the left side of the heart, then goes to the systemic circulation, oxygen is consumed. This is how the normal circulation works. In ECMO, what we do is, for example, this is one way of doing ECMO. So we take out blood from close to the right side of the heart, close to the right atrium, mostly from the right atrium. We take out the blood, suck it out, then get it oxygenated by externally by a oxygenator, then pump it back into the aorta. Okay, so basically we are bypassing the heart and the lung. Okay, we create a bypass circuit, and so the normal cardiac output flows like this, and when you put ECMO, the ECMO will flow like this. So if suppose the ECMO flow, if you take out all the blood reaching the heart, almost completely empty the heart, and then oxygenate it and give it to the aorta, hardly any blood will go through the native cardiac flow. Most of it will go to the ECMO circuit. Okay. And so we can give complete rest to the heart as well as the lungs. So even if the patient's heart and lungs does not work at all completely, you can keep the patient alive. Of course, the patient will not leave unless the heart and lung recovers. So whatever the disease producing the heart and lung damage has to recover. This is only supportive management. You can support the heart and the lung completely until the patient recovers. So this is how the ECMO works. And this is this kind of ECMO where you take out blood from the venous side and give it to the arterial side, from the right atrium and give it to the aortic arch. That's called a veno-arterial ECMO. Take it from vein, give it to the arterial side. Okay. So this can give both cardiac as well as respiratory support. Even if your heart completely stops, you can maintain the patient alive. Even both heart and lung completely not working, and we basically produce a parallel circuit. This is how we do it in children. So usually we take out the blood from the right atrium, okay, and then we get it to a pump. This pump generates the pressure. So it takes out the function of the heart. Then it goes to the oxygenator. Okay. This simple machine. It just basically something like a dialysis filter. We use dialysis at kidney. We might have seen that. Okay, it's similar to that. All oxygen passes through that, and then blood get oxygenated. Then is given into the arch of aorta. Okay. So in this patient, if the heart completely stops or the lung completely stops working, we can support the patient. So arterial ECMO. Suppose in some patients, suppose heart is working well, only problem is the lung. Like only ARDS is the heart is perfect. There is no shock or anything. And we can take out the blood from one of the main veins, like femoral vein or something, right? And then pump it through this pump is basically to take out the blood and get it through this oxygenator. It's not a pump strong enough to take out function from the heart. Then pass it through a membrane oxygenator. This is similar to our dialysis heating. Then it goes to the and give it back to the right atrium. So you take it from the venous side, give it back again in the venous side, close to the heart. Okay. So that means you are delivering oxygenated blood into the right side of the heart, so that even lung is not working, there's no problem. The oxygenated blood will go into the heart will pump it out. Okay, so this kind of ECMO if you use. So ECMO can be basically two types. If you take it from the venous side and give it to the venous side, that is called veno-venous ECMO. Veno-venous ECMO. And the previous one, we took it out from the venous side, right atrium, and gave it to the give it back to the arch of aorta. That is veno-arterial ECMO. Okay. So there we can cover both the heart and lung we can support. So our child was put on an ECMO. We used actually in this patient we used even though only lung was the issue, we used VA, veno-arterial ECMO, because of other logistical reasons of getting a too good IV access on the venous side. So this is the cannula which you can see in the right atrium. It takes out the blood from that, and then this cannula delivers the blood into the arch of aorta. All right. So this child was on ECMO, and as you can see, by this time, by day 18, the child's lung is completely white. There is absolutely no air. Lung is completely white, fully. It is called extubation. It's almost like a complete whiteout lung is there. Okay. So then we continued ECMO. By day 33, around a month's time, still the lung was showing a little bit of aeration. Still child is on ECMO. Lung is slightly better than previously. We hope that child will come out. Because we are treating the child for all other conditions, infection control and antibiotics and all that was covered, looking for all the cause for ARDS in the meantime. And by day 40, the lung is almost the same. There's very little aeration on the right side. Left lung is completely gone. So by day 40, we realized that this child would have much gone into the fibrotic phase of ARDS, and lung is never going to recover. But we have multiple trials of trying to wean off the patient of ECMO failed. Whenever you take off the ECMO, child was absolutely not expanding even with the conventional ventilation. It was like a rock, concrete lung it was. So finally we have to take off the patient, abandon the procedure. So, and in fact, patient expand. Okay. So this is how this is another ECMO run we had recently, last in December, then November, December, another bigger child. So I just wanted to show this picture to show the ECMO machine. Even though it looks a big like a big procedure, this is the machine. It's a very small machine. This is the HFR machine, of course. It looks a bit scary, but it's a very gentle machine. And ECMO, it does so many things, but it's very small. So that's why appearance are very deceptive. So this is the ECMO machine here. Very small. The smallest machine in the patient is the ECMO. It just contains a small pump and an oxygenator, nothing else. And there's some tubing to be connected to the patient. All right. So this is another bigger child which we had at ECMO in a couple of months back. Yeah. So that ends my talk, around 40 minutes. And these are a few of our publications on ARDS from our department. I'm happy to take any questions.
Thank you, Naru. Thank you for walking us through this entire pathophysiology of ARDS and also the various mechanisms how the ventilatory support works. Before we start the questions, I think there is one question from Dr. Vishnu Bhatt. Sir would like to know that if you start prone ventilation in the early stage itself, do you think that you can reduce the or you can improve the outcomes of ARDS? Is there any evidence to support this?
Yeah, that's a very good question. Yeah, that's a very good question. Yeah. So there are a lot of studies on this. Okay. So what we have learned from these studies is that what we are very sure is that the prone ventilation definitely improves the oxygenation. The lungs, the PO2, SPO2 will increase, and then we are able to decrease our ventilator support to a certain extent. But whether that finally translates to better outcome for the patient, does the patient get extubated early, does he leave, and does he go home? The evidence is not strong. In fact, consistently till recently, the evidence was almost saying that there is no difference in the final outcomes. The recent 1 or 2 trials have shown that there may be a marginal benefit. Okay, so as of now, the current state of evidence says that final outcome not much benefit, very extremely doubtful benefit, only for making our day-to-day life easier if you do prone the patient, because we can manage with much lesser settings and we feel happier seeing a better oxygenation. Yeah.
Okay. There's this campaign by Government of India, right? Backing up. That is what I think they are calling this, where they say that recruitment of the lung alveoli is much better if you keep the people in prone, especially in COVID status. Is there, because I remember distinctly when you were talking, you said that Doesn't seem to work much in normal people, but especially when you are battling with some respiratory problem, it might. So do you think that is based on real scientific evidence what this campaign is coming out with?
Yeah, I see. If you're at home and if you don't have much oxidation problem, then I don't think this phone will, looking at the scientific aspect of it, it may not benefit you much. If your lung is significantly damaged, the parenchyma has significant damage, and then you're hypoxic, and if you lie down, it's pain for a long time, you can develop your hypoxia can worsen. And some of the hypoxia can improve if you can. So that's not applicable for at home. I feel that only for hospitalized patients, especially, it will be most useful for patients in the ICU. Even in the wards, I don't think proning is going to help much. Yeah, maybe instead of giving 5 liters of oxygen, maybe you may need 4 liters of oxygen if your lungs are really bad. But that is not going to affect the way whether you finally survive or you go to the ICU or you go home. Those outcomes, I don't think it has any significant impact.
Yeah, thank you. Can you actually tell us a little bit more about the role of corticosteroids in ARDS? I think that was something which I was looking for in your talk.
Yeah, I purposely
So
avoided
that's one controversial area. So do you think that we can take that as a question?
Yeah, definitely. It's a very interesting question. I mean, I know it's a holy grail, and there are innumerable trials. Steroids is one drug which all of us love. When we have nothing to in our hands, and when we are pushed against the wall, we always use steroid as the last weapon. So yeah, there are a lot of trials in ARDS, and all of us are aware of the recent recovery trial results in COVID, which says that steroids improves outcomes in people with bad COVID who need for hypoxia, basically who are need respiratory support or who are on the ventilator. So as a concept, it makes some scientific sense. So, but there are, as we know, steroids is a double-edged sword. So when we give steroids, it suppresses the inflammation. So if the cause of ARDS is predominantly an inflammatory damage, say for example, you have you aspirate kerosene or something on, or you have a chemical damage, and then or you have an inflammatory disease like SLE or where the inflammation is driving your ARDS. Then of course it works beautifully. A steroid will produce a dramatic response. But if you are having a serious infection, say some very bad bug, bacteria, and that actively damaging your lung, and then at that time, if you give steroids to the patient, that can be counterproductive. Okay. But if you are like how it is working, this is my personal opinion or my personal view. How it worked in SARS coronavirus, COVID-19 is perhaps because most of the patients who go into ARDS by COVID, that is happens in the second week after 10 days, 11 days. By that time, the virus has disappeared from your body. And what is driving that process is your body's dysregulated immune system, which has gone kind of haywire. So if that is the main problem driving the ARDS, of course, steroids will help. So the issue is when you have a patient in front of you, how can you be sure that what is driving the ARDS is not the bug assets straight away actually producing, multiplying in alveoli and producing damage, or is it your some kind of inflammatory response which is primarily driving it, or what is the balance between these two? So that's why studies in ARDS, there are a lot of studies in steroids in ARDS. Some of them are shown that increased mortality, some of them are shown benefits. Overall things are shown that it is of questionable use. My personal view on that is that there's definitely a subset of population in ARDS where steroids is beneficial. As of now, we are unable to identify them very early enough in a very objective manner. If you're able to pick them up in an objective manner, then in that subset, I'm sure steroids will make a difference. Giving it universally to every ARDS may not be a good idea. But I think in COVID, I think ARDS, you should use it because evidence is quite strong for that. In other ARDS, I think you have to take the decision at the bedside, depending on what you think is the main pathophysiology in that patient. And in future, some biomarkers or something may come up, or some scoring system may come up where we can reliably identify the subset of patients with ARDS who will benefit with steroids. Yeah. I hope I did not make it more confusing.
Okay. But would you like to say something? You want to ask some other questions or any comments before we move further to other questions? That's it. Hello. Hello.
Hello.
Yeah. Can you actually tell us a little bit about long-term follow-up of these children who undergo frequency ventilation and ECMO therapy?
Yeah. So, I mean, this is another area where actually not much data is available. Okay. In fact, we have done some follow-up on this, but this is the long-term outcome from ICU is something which not many people are looked at, especially in this patient with ARDS. There are not many data on this. Our experience is that the adverse outcomes, like long-term, if you follow them up at the end of 1 year or 1.5 years, I think around 1/4 of them still has some issues. Okay. Roughly, it's not purely ARDS. Roughly, the patients who come out of the ICUs and go for a long time in our ICUs, pediatric ICUs. So I'm sure ARDS also will fall around roughly that. I think around 1/4 of them, or maybe 1/5, will have some lung damage and residual lung damage, which may like can produce something like they may have some breathing problem, or their the functional reserve of the lung is actually decreased. So these guys can decompensate if they get something else, or they may easily develop, say, COPD or something when they are older or something like that. There is definitely a possibility. But the numbers, we don't know the actual numbers. The data is not there.
What about neurological outcomes? We have spoken about lung outcomes and respiratory outcomes.
Usually they're not bad. Okay, unless the patient had some severe hypoxic event, some cardiac event, or during even ECMO, even after ECMO, especially children, the neurologic outcomes are usually good. Unless they had a neurological complication during the procedure, they had either a prolonged cardiac arrest, or during ECMO, since we fiddle with the major vessels, carotids, and and all that. Suppose you get a stroke or something, you get a thrombus which is embolized or something like that happens. If otherwise, usually they do well. CNS spike, they're not bad. Some numbers I don't have. Sorry, I don't know the exact numbers.
Taking that question. Yeah, thank you for taking that question. Over to Dr. Bhatt. Sir, would you like to ask some questions, or you want to come or you? You're muted, sir. Okay. You will be unmute yourself. Sir.
Yeah, now it's got unmuted. One thing about this steroid, what Dr. Narayan was asking, talking about, in all these infections, initially there is a inflammatory mediator release, which I think to some extent gives how to diagnose, and it may be helpful. But once the inflammatory storm develops, probably the anti-inflammatory drugs like steroids become beneficial. Even in COVID, I think when they become very sick, probably the steroid helps, isn't it?
Yes, sir. Actually, yes, sir. So it is sometimes. Yes, sir. It is. Yeah, the issue is that it's very difficult to identify at what stage. In fact, most of the studies which use steroids to the later half of ARDS, after 1 week, they have shown worse outcomes. They're saying that outcomes are better if you use very early, the first few days, in the first 1 week. In fact, most of the studies which are used later, after 1 week, have shown after ARDS setting, has shown worse outcome because it decreases nosocomial infections and other complications becoming there. So it is.
Monitoring of the inflammatory mediators probably will help.
Yeah, sir. We are learning from that, sir. Yeah. I think soon, hopefully, in the near future, we'll get more clarity on this. So even in our setup, we are not using steroids routinely for all ARDS. We mostly avoid, because most of our crowd comes with very serious infections. So we are very hesitant to using them when they have an active infection and going on. But of course, we have used few patients occasionally. In fact, this particular patient, we use steroids. When the other ECMO patient also, we use steroids. Yeah.
Because when they suppress the immune system, probably the infection becomes worse. So it does more harm. But when the inflammation goes out of control, then it helps, because there the problem is inflammatory storm, where these.
There's also another issue with the things. People say that the proliferative phase and other healing process, steroids may inhibit that also. So we don't know. So the healing may get delayed if you give steroid because inflammation is needed for healing of the lung also. So that's why steroid is always a double-edged sword. We know that steroid inhibit wound healing. So the lungs are injured and alveoli are broken, they're healing. So we don't know. These are the issues.
I think we'll learn in days to come. I think very nice presentation done about job. And of course, he is also in charge of the DM critical care in JIPMER. And his brother is head of the department of nephrology, Srijit Parmeshwar. So both don't speak much, but they do good work. So both. And I congratulate you for a nice talk.
Thank you, sir.
I think that Dr. Anushri Haldir or somebody was trying to ask some question.
Yeah, please.
From anesthesia.
Yeah. I know you can post your questions. There is any.
Dean wants to add anything?
Sir, sir has to leave because he had an urgent meeting. He had to leave the talk somewhere halfway through. So he has sent his best wishes. The other thing which I was quite intrigued when I was trying to look up for this talk, no? If you look at this pediatric critical care literature, you come across so many acronyms and so many abbreviations. There is one MS, there's one SARI, there is one PRES, there is one SARS, one SIRS, one TSS, then SSSS. So many abbreviations are there, and each one, I think predominantly all of them are looking at the same pathophysiology, but describing it in different terms, either based on etiology or based on where this has been reported or something like that, right?
Yeah.
Very confusing kind of terminology. I thank Dr. Narayan for taking this very, very interesting and confusing topic, dissecting it out into very simple terms. And most important, actually, like what I really liked about the presentation is that even though it's a very abstract topic, you actually context it in the case of a clinical patient and how his progression occurred over a period of time, and then try to go back and see how you can correlate it with the pathophysiology. I think moving from concrete to abstract, no, which KRS always keeps saying, don't go from abstract to concrete, but rather go from concrete to abstract. I think that drives the point very nicely. I thank Dr. Narayan for wonderful presentation and very interesting slides on behalf of the Scientific Forum of AVMC and VMRF in general. Thank you.
Thank you, madam. Thank you, sir.
And we will be sharing the YouTube link of this talk as well as the certificates of participation can be downloaded by clicking on the link you will be getting today evening. So that is the information for the participants. And we will be back again on Friday, 3 o'clock. We have a very interesting talk lined up next week also. We are going to talk about peripheral vascular disease and what interventions can be made for peripheral vascular disease. And we will take it in the context of diabetic patients with peripheral vascular disease. What is new and how we can actually do. That is the talk for next week. So Dr. Shekhar, he's a consultant vascular surgeon. He was formerly the HOD of vascular surgery unit in MMC Chennai. So he will be giving the talk that is going to be on next week. So we'll see you till then. Till then, stay safe and have a good time. Thank you very much. I will close this meeting now. Thanks, Narayan. Thank you, sir.
Thank you.
Thank you, Narayan.
Thanks, sir.